welcome to ABA Inside Track, the podcast that's like reading in your car but safer. I'm your host, Robert Perry Cruz, and with me as always are my fabulous co-hosts.
Hey, Rob, it's Diana.
And it's me, Jackie. All right, so just so you guys know, next year when we start this podcast again and we keep doing it, I want to go first in the introductions.
You want to do the hey, everybody? Do you want to do that?
No, I don't want to do the hey, everybody. I want to say my name first.
Okay.
Like Beyonce, say my name.
We're going to remember that for later in the future?
I've been third for 4 years now, and the Beyonce and me is ready to be first.
It's like the old 80s sitcoms, though, where it's like whoever had the "and" credit, they were like the most important actor, you know? Like, and Jackie! And you come in the door like, hey, I'm here.
That's true.
I'm on your show.
You're the Kramer.
Yeah. I am the Kramer of this group. Thank you.
But this is not a podcast about how to do the credits on 80s sitcoms. It's a podcast about behavior analysis and behavior analytic research, where every week we pick a topic in the field and we discuss relevant research articles. This week, we're going to be talking all about traumatic brain injuries and acquired brain injuries and treatment. And for some of our episodes, we've got the three of us because they're episodes on topics that we know a lot about. Sometimes we have a researcher that we wanted to get a hold of because they're experts in the field and we said, tell us what research. And sometimes we kind of have like a magical moment where we were doing some, previewing and looking at articles. And as I was starting to look at articles, I typed in, traumatic brain injury and behavior analysis. And one name just kept coming up over and over as doing all this like fabulous research. And that was Dr. Megan Heinicke. And we were very, very lucky that she was able to come on the show. So we are joined by special guest, Dr. Megan Heinicke. Megan, thank you so much for coming on the show. We really appreciate it.
Thank you so much for having me. This invite really kept me going through this week. So again, right now we're going through COVID, lots of negative stuff. This was a positive thing to look forward to. So thanks so much for the invite. I'm really happy to be here.
Well, we were very excited because after doing some kind of that prep work, and it was like, if we don't get Dr. Heinicke on the show, it's going to look real bad for us. So we were so happy that you accepted our invite. Also, for listeners out there, Diana, this was a listener request episode, was it not?
It was. Listener Ashley wrote in to ask if we could talk about TBI. So we're super happy to do that. Thanks for asking, Ashley. Special
guest and a listener request. Beautiful. Love it. Before we get started, I want to make sure everyone out there knows some of the citations that we'll be discussing, in addition to a lot of the other work that Dr. Heinicke has done and is currently doing in the field of traumatic brain injury treatment. But let me get those citations to you first. First article that we'll be sort of discussing as part of our framework tonight is Applied Behavior Analysis in Acquired Brain Injury Rehabilitation, a meta-analysis of single-case design intervention and research by Heinicke and Carr from Behavioral Interventions, 2014, using differential reinforcement to decrease academic response latencies of an adolescent with acquired brain injury from the Journal of Applied Behavior Analysis, 2009 by Heinicke and Carr, again. And also, we'll be discussing expanding the consumer base for behavior analytic services, meeting the needs of consumers in the 21st century. That is by LeBlanc, Heinicke, and Baker from Behavior Analysis and Practice, 2013. And with our citations out of the way, let's get into the discussion. And Megan, why don't we start by, if you don't mind, letting our listeners know a little bit about who you are?
Sure thing. And thanks again to Ashley for the request. I think it's great that you mentioned TBI. So I am from a super, super small town in Western Michigan. It's called Kent City, but that's a misnomer. It is not a city. It is a village. It has only one traffic light, and it's a four-way stop, so it's just a blinking red. And we got a subway attached to our gas station when I was in high school, and that was the biggest deal ever. So that's where I'm from.
Getting some like Twin Peaks vibes, Megan, from like your town. It's like, ooh.
Yeah, just think a lot of fields and farms.
Okay.
It's about right. So I ended up going to Western Michigan for undergrad because I was planning to be a music major. So I played flute and piccolo, and I wanted to be a music teacher to begin with. And I got to Western and I was super nerdy, surprise, surprise. And I was in the honors college. So for the honors college in your first year, you have to take what they call cluster classes or cluster courses. So courses that hang together by topic. So I selected psychology and biology, and they both had labs. And coming from my village of Kent City, we didn't have anything psychology related in high school, no courses whatsoever. So I wasn't interested in it, didn't have any kind of background in it, and really thought of psychology like, the person on the street thinks of psychology, of sitting in an armchair, Freud and all of that. So wasn't interested. But in week 2, I changed my major, just like every parent's dream. I changed my major right away after buying me an expensive instrument. Oh, goodness. And I did that because the psychology class was just so enthralling. So I was taking an upper level psych class as my first intro to psych, and it was intro to ABA with a rat lab. So every principle we were learning in the classroom, I was seeing in real life with my rat, who I named Mr. Mistopheles, by the way. And he was fantastic. And I just fell in love with it. I never thought that was psychology, that had anything to do with psychology. So I changed my major, and at Western, it shouldn't really be considered a bachelor's in psychology. It's a bachelor's in behavior analysis. The classes are all very behaviorally oriented. And we have to do a practicum to graduate. I ended up doing 5, again, because I'm really nerdy, but it took that long,
oh my gosh.
I know, to figure out what I really wanted to do, kind of where my reinforcers were in the field. Because the first practicum, it was the common practicum. It was EIBI, children with autism. And I felt like the worst person on this planet, I have to be honest. I would come home and cry because I didn't like it. I didn't like working with kids. And I thought, who on this planet doesn't like working with kids? I just didn't like it. I thought I was a terrible, terrible person. And at that time, being an undergrad, I was misinformed and thought that ABA equaled autism treatment. So I thought, I don't have a home here. I need to find another major. So I picked up a double major in criminal justice because my new vision was I was going to be Jodie Foster in Silence of the Lambs.
Yes, you were. Yes,
and it took, again, less than 2 weeks to figure out that wasn't for me. I am in no way a badass.
You didn't solve any, major crimes with serial killers across the country?
No, I just learned that I did not like those classes and group work was terrible. And so I came running back to psychology and was lucky enough to enroll in Jim Carr's advanced ABA class as an undergrad. And there was one day in the class that he took off from typical lecture where he just talked about getting into graduate school and gave us the lay of the land. And I never thought about going to grad school whatsoever. And on the last slide of his presentation, he had all of these subspecialties, or what we're now considering our practice areas. And the last on that list was rehabilitation. And it was a true light bulb moment. I know that sounds really cheesy, but it was. So I have a family member, I have my father, who suffered a TBI before I was born. He was in a really bad car accident, suffered a severe traumatic brain injury, was in a coma for about a month, long road of rehab. And when I was in elementary school, I had a best friend, and he also ended up having an ABI. So he had a non-traumatic injury that was due to a brainstem tumor that was entangled in his brainstem. No one in our area, no one in Grand Rapids would do the surgery. So he was life flighted to New York City to have a surgery done pro bono. It was actually on the cover of Reader's Digest, believe it or not. And so these 2 areas of my life were really impactful because I did see what absent services looked like for families. And I could absolutely see the tie between behavioral principles and all of the difficulties that are encountered by professionals in rehab and what the clients were experiencing. So I thought, that's it. That's my area. What do I do now? And luckily, Jim and his wife, Linda LeBlanc, they're very, very well-connected folks. And I was really lucky to just happen to be in a program with them and get to know them. But Jim connected me with his lab mate from grad school, Dr. Mike Mazzoni, who was one of the only people at that time doing this work whatsoever. So I upended my life and moved to Arkansas for a summer as an undergrad to do an internship at a post-acute site. It just took one day. That was it. I knew that I had found my place, and really the rest is history. So I applied to Western Michigan's doc program to work with Jim and Linda, and I got a random call one evening in the spring saying, yeah, you're in. However, we're moving down to Auburn University. Do you want to come with us and be our first PhD student down there? And I immediately said yes, but I literally had no idea where Auburn was. I thought that it was in Michigan. I thought it was on the east side, like near the thumb of Michigan, near Saginaw. Yeah, it's not. So I moved down and I lived in Auburn, Alabama for 5 years and got my master's and my PhD there in cognitive and behavioral sciences, and ended up putting myself on the market a little early as ABD, and very thankful that I got the job at Sacramento State, moved here in 2013 and have been here ever since.
That's a good story. I kind of wish I could look back at my academic career and be like, and I did this and this signal and I loved this. And I feel like I was just happy to graduate from college way back when and sort of stumbled into the field a bit. So this is a very elegant trajectory for you, Megan. Like Jackie said, very jealous of that. That's awesome.
I feel like you're like a true Skinnerian there because you really dropped everything when you found something interesting and just went for it.
Yeah, it was really hot in Arkansas. I did not fit in, but it was worth it.
I grew up in Arkansas 2 different times. It is very hot there.
Oh, it's so hot.
I lived in Alabama, also very hot.
Yes.
Now you live here where it's very cold.
Mm-hmm.
Sometimes hot, but often cold. So, Megan, when we talk about traumatic brain injuries, acquired brain injuries, could you kind of walk us through kind of the general definitions and differences between the two? Because, I mean, I sort of read, your articles as ABI being more of kind of an umbrella term, but I don't know if I'm sort of giving it short shrift as a definition. So would you mind kind of clarifying those terms for us?
Oh, absolutely. No problem. So ABI, or acquired brain injury, that is an umbrella term. You're absolutely right. So it covers all brain injury. And under that term, there's kind of 2 major branches is how I would think of it. One being traumatic injury, which is what I think people typically think of when they think of brain injury. And then there's the other branch, and that's your non-traumatic injury. So overall, both types, they occur after birth. They're not hereditary, they're not congenital, not degenerative. But traumatic, of course, is what it sounds like. It's an external hit to the brain. It's an external force. And they can either be contact injuries. Again, I think that's what we think of when we think of brain injury. So those are things like a fall or an assault, a gunshot wound, a blast injury, that sort of thing. And then you have your traumatic inertial, which you don't actually have to hit your head to sustain a traumatic brain injury. That's when you have a non-contact injury. So your brain is accelerating too rapidly within your skull. So this could also be a fall where you catch yourself and you actually don't hit your head, or a motor vehicle accident like a whiplash type of experience. Your non-traumatic injuries, those are your internal insults to the brain. So that's something like a stroke, anoxic events like a near drowning accident, tumors, infections, neurotoxic poisoning, and incidents like that.
We're sort of looking at sort of patterns of TBIs and ABIs. Is there a sense of, these types of injuries tend to lead to these outcomes or these types of rehabilitation, or this level of intensity probably means this or that? Or is it really one of those things like with the brain, like we know a lot, but we don't even know close to everything, where every injury is going to result in possibly a set pattern, but not necessarily a similar pattern between different patients? I mean, is there sort of like a flow chart, or what's that like?
No, it's the latter. You hit the nail on the head. There's a saying in brain injury rehab that once you've seen one brain injury, you've seen one brain injury. So everybody is so different. And I honestly think that's also what draws me to this population. I get bored quite easily. I'm a professor for a reason, because I teach, I do service, I do research, I change my areas of research. And I like that novelty. Well, that's what you get with this clinical population. They will keep you on your toes. I guarantee it. And I love that, because it really highlights the generality of our field and what we can do with our principles. But you're right. We know a lot and we don't know a lot. I would say, speaking generally, those with more severe injuries are likely to experience more consequences, or what we call sequela, in the field that put them at risk for long-term disability, or requiring more rehab to achieve better functional outcomes than those with mild injuries. But it really does depend on the injury.
You spoke of rehabilitation as something that you work on. That's something that you've had family members and friends who've gone through the rehabilitation process. Is that something that is similar to the outcomes, is just different for every person in terms of you're going to see this doctor, that doctor, but then you might go to this outpatient location. You might do OT. You might do something completely unrelated. You might have a behavior analyst you work with. Or again, is there like a set amount of care given to individuals with a traumatic brain injury?
No, there is not. It's quite hectic, I would say, for survivors and their families after injury. Navigating what we call the continuum of care is incredibly complex. It's acute care, so your ER, your ICU, neurotrauma units, post-acute, so that could be inpatient rehab or subacute rehab, a transitional type of program that's oftentimes residential if you have the funding. We'll get back to that in a second. And then long-term as well. Sometimes a skilled nursing facility, which is a terrible place, I believe, for someone with a brain injury. Outpatient therapy, day treatment programs. Hopefully, the goal is community and home-based programming. and also school and vocational training, depending on the age at which the injury was sustained. But overall, I would say, again, the treatment depends. It depends on a lot. It depends on the severity of the injury. It big time depends on your funding and your geographic location and what you actually have access to in your area. Good access, that would likely include that continuum of care that I mentioned, kind of in that order. And it would be hopefully an interdisciplinary, if not a multidisciplinary team. And those professionals that are around the table would depend on the presenting needs of the client. So OT, PT, speech, neuropsych, social work. You're going to have physicians at the table, psychologists, psychiatrists, neuropsychologists, and hopefully a behavior analyst.
And I guess that leads to the next question of how did behavior analysis kind of get into the field of, treatment for traumatic brain injury? Was this just something that, there were a few behavior analysts who just found themselves on medical teams? I mean, I sort of know you mentioned some general practices of joining a new discipline as behavior analysts in the article you wrote with Dr. Baker and Dr. LeBlanc. I guess, is there like a pattern? Is it just sort of idiosyncratic? Like some behavior analysts just found themselves in this field one day? Or
I don't know the clinical history. That's something I would love to know. I should ask Mike Mazzoni a little bit more about it, see if he has more information. But what I can gather from what's been published is that it was kind of idiosyncratic. Like, for example, some of the earliest work is Murray Sidman's work. And he was in an inpatient hospital. A director came to him and said, I have these stroke patients. I don't know how to assess their language because they had aphasia, very severe aphasia. And that's really where that work started. But then there's a big gap in the literature after that. And then you start to see in like the early 80s, some behavior analysts publishing some really basic articles, pretty much in Java. So the one that I kind of coined as one of the first ones of that generation is Boyle and Greer. And it's operant procedures in the comatose patient. And it's just using very simple operant procedures to get folks to respond to verbal requests, like to move their finger or squeeze their eyes using contingent music. And what was kind of interesting there, and gets back to your point earlier, was that they did have mixed results where there was more success with those who had been in a coma the least amount of time. So there seemed to be a negative correlation with coma length and success.
I know we're all a very young field, this behavior analyst, but it is always funny to think that there was so much different style of work from way before, the insurance reform made, hey, if you do ABA equals autism. It's really nice to know that that's less and less, I think, an issue these days. There's more branching out in the field. When we talk about treatment for traumatic brain injuries or acquired brain injuries, I know you've published, a number of articles on various types of treatments that you've used. The one that, I sort of just picked one that was, kind of a shorter one because some of the other articles, were a little bit longer and robust. And I know you had some work that you will be publishing soon. So I sort of just picked one on the decreasing academic response latencies. And, reading it, it's a short paper. It kind of is just a brief work using a token economy. So if you crossed out, brain injury and just put autism, I'd say, oh yeah, I know what this is. I've seen a million of these papers before. Was this just part of your kind of graduate work and your PhD work where you knew the individuals you were able to work with and you were just using behavior analytic principles to try different treatments? Was it part of a treatment team, some of that early work?
That's a great question. It was actually my undergraduate honors thesis.
Oh, wow. So that far back.
Yeah, it's that far back. That's my first publication. Yeah.
Yep. Oh, I'm glad I picked it then. I
know when I saw that one on the list, I'm like, oldie but a goodie. That was a lot of fun. So I was down in Arkansas for that project. So I had an internship with Mike Mazzoni. That was my first internship experience where I moved to get clinical experience. And I was placed in their pediatric wing. So I ran a fluency-based classroom. So I got a new group of kids every hour. And there was one particular patient there who was 16, had a seizure disorder and hydrocephalus as well. And she took forever to respond to any request, but particularly any kind of academic request from any of her teachers. She was what we call an excessive dawdler. And it was very dramatic. It just took her a long time to get her pencil out. And you could tell all the teachers were just done with it. They were really frustrated. They were very short with her. There was a lot of punishment going on. And then you would see the effects of punishment on their relationship. So I thought, I'm here for a summer. I'm going to take this on. So I ended up just searching the literature. I found an old article. I think it was with an adolescent or an early adult with Asperger's. And I ended up replicating that in brain injury. So I just found the problem and thought, how can I solve this and how can I do it empirically and gather data in such a way where this will be publishable? So that's how it came to be.
And I mean, has that been kind of similar thread in some of the other treatments and some of the other research you've published in terms of, replicating something that had been done with a different population, but the principles seemed sound to, the problem at hand and the issue at hand?
Absolutely.
That's always nice.
Yeah, absolutely. So now it's different though. That was my only, I would say, problem behavior reduction study. I'm much more trained on the acquisition side of things. And most of my research right now is focused on the reacquisition of verbal behavior after injury and the assessment of verbal operants. But I would say now that it's more of a systematic line of research, when that study was just my first project, and it was definitely a clinic-driven project, when now it's much more of a protocol-driven project in my lab.
So that's very interesting that you're focusing on the skill acquisition, because I know in looking at your meta-analysis, it does seem to be that the common needs for individuals are either the skill acquisition or the problem reduction. And I know in that you mentioned how so many individuals don't really, or at least it's not in the publications, at least the single case publications, those individuals often aren't being asked, what kinds of treatments they want to use. And I could see the literature sort of skewing towards the problem reduction realm of things, because again, well, that bothers everybody. So we better work on that first, rather than the individuals like, no, I need help with certain skills that I used to be able to do fluently and I can't anymore. I hope that's not the case, but I'm kind of worried maybe it could be. I don't know.
When we started that meta-analysis, I was actually quite nervous because we followed, the systematic roadmap for conducting a systematic review and meta-analysis. So you have very prescribed procedures that you follow. You go in without any kind of hypothesis. You try to limit your bias as much as possible. So you really don't know what you're going to find. And if I had any hypothesis going in, I thought that we would find all reduction studies, no acquisition, and I wouldn't have enough to do any kind of quantitative analysis of the acquisition, but I was pleasantly surprised. So it ended up being kind of a 60-40 split of reduction versus acquisition. But I would say why I focus on acquisition is, once, yes, I'm more trained in that area. But like you pointed out, I feel like folks going into this area, they're very likely to focus on problematic behavior because that's probably what they're going to be brought in to consult for, because that's what we're kind of known for in rehab settings. So I like to focus on the stuff that really hasn't been done as much, because that's where we need more evidence to say that what we're doing is truly evidence-based. So the tables in that publication where we list the intervention categories and whatnot, that's really used as a roadmap for my lab. If my students are struggling to come up with any kind of idea for their thesis, I say, look at that table and pick one, because there's so much to be done. I'll support any idea you have as long as it's one of these areas that doesn't have a lot of evidence, because we need more evaluations.
Do you feel like when you go in and do that skill acquisition, you get a little pushback from others because we are so well known, in other fields as treating problem behavior?
Now, in the clinical experience that I have, I would say not as much pushback, because at the time I was brought in as an intern, behavior analysis was really in the fold. And those before me, namely Mike Mazzoni and Dixie Eastridge, they had spent so much time getting rid of those preconceived notions of behavior analysis and showing all of those interdisciplinary folks that we can do both, that we're skilled in both. So I didn't really have to fight that then. I would say now, yes, if I'm trying to branch out and use some of the strategies in the LeBlanc paper that you mentioned, I do get pushback when it comes to skill acquisition, namely because there are so many other professionals that serve this population. And a lot of what they do does have overlap with what we do. Like OT is a great example. So if we're doing kind of daily hygiene skills, they do that too. If it's language, well, SLPs do that. If it's anything related to cognition, even like name-face relations, which is something my lab is beginning to focus on now, well, neuropsychologists also do that. So I've received that pushback a lot since arriving in Sacramento and trying to get my foot in the door with rehab centers. So I'm going at it more now from a research standpoint than a clinical standpoint, and hoping to still build those relationships. But that's been, I would say, my biggest struggle.
I think that's certainly going to be true of any field that's been around for a while is, well, I got to do that. Don't need your help with that. I don't want to jump to that article quite yet, but certainly the article that you did on expanding the consumer base, I think very well kind of plays out that like, how can you be nice about the idea of like, I'm here to help, or like, I'm just trying to give you some extra research ideas, or just making friends and just trying to sort of get involved, like ways to get involved with the new field.
Mm-hmm.
I love hearing you talk about skill acquisition, because I think that we have, as behavior analysts, so much that we can add in that capacity. And of course, a matter, like you said, of showing someone else that we do have something to add, but we can come in and know so much about stimulus control and prompting and environmental arrangement that, that might be a focus that is different than someone who's been focusing as an SLP or an OT. So I think that there's ways that we can be really complementary to those other acquisition services, as long as we're able to demonstrate that that's a skill that we have.
Absolutely.
Megan, we spoke about how the injury itself is going to be very different from each individual, sort of what their outcome is going to be. We didn't talk too much about exactly what would be in the process of rehabilitation for, say, behavior reduction or for skill acquisition. And you sort of mentioned the broad categories in your meta-analysis, but would you mind going into a little bit more detail as to what are some of the more common needs for services or for treatment for individuals with ABI or TBI?
Sure. I really think what behavioralists that are trained in other areas and other practice areas should know is almost everything they've been trained in is transferable to this population. You're going to use the same darn procedures. You might have to think about them slightly differently in terms of stimulus control, because instead of working on acquisition, we're working on rehabilitation of a skill, reacquisition of a skill. It's very often the case that the individual you're working with had that skill in their repertoire. They were fluent in it. And now, for whatever reason, they are not. So you have to think about things like medical concerns and physical ability to complete a task. I know it's one of our ethical standards to always ask before we intervene, is there anything medical going on here? And we have to do that in ASD and DD work, but you have to do that constantly with every single client, very carefully in brain injury, because those types of sequelae or consequences are more likely to happen. And you have to consider those variables a little bit more so than you would with other populations. But I would say overall, the interventions are the same, but you're going to have to think about things like, do you fade the intervention? Or is it more appropriate for this population to keep certain components of that intervention in place, like a prompt in the natural environment? For example, I worked with a man who lost the ability to brush his teeth. So he worked on, of course, chaining, got that back in his repertoire, but still, because of memory issues, after we tried to kind of pull away those components, we realized that task analysis needed to stay in the environment. And for him, it was appropriate to do so. So we just needed to find a non-stigmatizing way to do that. So we ended up putting that TA on the back of his mirror in the bathroom so he could open up that cabinet, see it, use it as a prompt, close it, and brush his teeth. So I think thinking about stimulus control and what you leave in place, those are the big differences I see.
And Megan, when we talk about kind of behavior reduction treatment, I don't know, I sort of had it in my head before I started looking at like your meta-analysis and any of the work you've done as often sort of behavior reduction related to difficulty with what we think of as like executive functioning skills. Is that more something that I probably took from like media or movies in which people have traumatic brain injury? Or is that a common need for rehabilitation treatment?
Absolutely. It's a very common need. It's a very common skill deficit. So that's something that a behavior analyst can work on in conjunction, probably with an SLP and a neuropsychologist. So I would say probably more of a interdisciplinary approach would be best if that were the target.
And are there any other kind of treatment targets that you have more generally either worked on or seen in your work that, a behavior analyst who's sort of just learning about, this practice area would say, I didn't know that would be something that I would be, asked to work on, or that would have been an issue or something that needed to be targeted for an individual with the TBI?
One thing I see often, and that we don't deal with as much with little kids on the spectrum, is just showing up to therapy. Just showing up. That shocked me when I was first an intern in Arkansas. You would get ready and your clients just wouldn't be there. They're back at their residence and they're like, no, screw you, lady. I'm not coming. I'm fine. I don't need your therapy. Right? So just outright refusal to participate and attend is something that you often have to focus on right away. And is something we don't often think of when we're working with kids.
Well, Rob has done a lot of reading about school refusal, and that's a big area of interest for you, Rob, right? He's staring at me like he has no clue what I'm saying. I don't know why.
Well, a lot of schools in the country aren't open fully. So, the problem hasn't come up quite at the same way as it used to. But they don't show up to the Zoom calls or whatnot. I'm just trying to think, I guess, how do those two, what are the mechanisms? Are they the similar? I'm just kind of suddenly wondering, I wonder how similar would we consider the behavioral mechanisms of not coming to, one's treatment as to I'm not going to school. I mean, I would guess they're probably similar ones. An individual going for rehabilitation probably doesn't want to go. And Megan, stop me if I'm way off base, because they have something else they'd rather do, or because they don't enjoy whatever work you're going to ask them to do and they'd rather avoid it completely. I mean, I would guess those are common. Or perhaps they're nervous and they are with a caregiver that they feel more comfortable with, and you are a scary doctor that they don't want to engage with.
Absolutely. I think a large part of it, too, that's different in this population is the memory deficits that you see and deficits in self-awareness. That is a big issue that I've heard some behavior analysts start trying to behaviorally conceptualize at conferences recently, and I'm excited about that. But I have seen several cases. I didn't think it was true reading about it in textbooks until I saw it. But there is a phenomenon that occurs after injury where you can be completely unaware of your deficits. You don't think you need help. You think you're fine. I've literally seen a woman scream at a physical therapist and spit at him saying, I can effing walk. Yet she's paralyzed from the waist down. I don't want to be in PT. Screw you. I'm fine. So that is something that is quite different, I would say, as a target behavior that is kind of residing on top sometimes of just attendance and showing up.
There are probably some similarities, but that would be very different than school refusal, where there's usually somewhat of an understanding of why something is not happening. Or, I don't know that many kids who say, I don't need to go to school. I've learned everything that's in the curriculum beforehand.
Yeah.
Not having that level of understanding.
I wonder if there might be overlap with some Alzheimer's patients in that regard, but I haven't worked with that population myself.
Mm-hmm.
Yeah, I think there is some overlap between the two populations. I've not done much work in that area as well. I have in terms of TBI in the elderly and kind of going down that aging road. And then, unfortunately, folks with TBI especially, they are at higher risk for developing things like Alzheimer's disease. So I've seen it in that realm, but I haven't worked specifically with just that population of having that degenerative condition on top of having a brain injury very often.
Well, why don't we take a quick break, and then when we come back, I would love to get a little bit more in-depth into your meta-analysis and then a little bit of moving into new practice areas. So we will be right back.
Do you want to be a BCBA?
Sure, we all do.
Now you can come to Regis College in Weston, Mass. to get your graduate degree.
Choose from any one of these courses.
Masters of Science in Applied Behavior Analysis.
Masters of Science in Special Education.
Dual degree in Special Ed and ABA.
Or be eligible for your postmaster's certificate.
You can complete your degree and be ready to sit for the exam in 2 years. And our 2017 grads had a 100% pass rate on the BACB exam.
Come enjoy practicum placement support, ethics mini handbooks, PhD-level professors, small class sizes, and a service trip to Iceland.
If interested, don't delay. Supplies are limited. Learn more at regiscollege.edu.
Again, that's www.regiscollege.edu, regiscollege.edu. One more time, www.regiscollege.edu.
See you there!
And we are back talking with Dr. Megan Heinicke about traumatic brain injury. But before we get back into the discussion of her research, I want to remind all of our listeners that ABA Inside Track is ACE approved. By listening to our show, you can earn 1 learning credit. Hooray! All you need to do is, finish listening to the show and then go to our website, abainsidetrack.com/getceus. That's GET-CEUS. Go there and you just need to enter in 2 secret code words that we've hidden in the episode. And these code words this week are courtesy of Dr. Heinicke. We're very happy to have some fun new code words. The first of these is Jodie Foster. JODIFOSTER. T-E-R. You can put it in as one word or two. Jodie Foster, the actress from Silence of the Lambs, as was mentioned, and also other fabulous films like Candle Shoe, the Disney movie where she and Helen Hayes have to find treasure in an old English house. It's on Disney Plus, folks. They're not paying us for this plug. I'm just putting it out there. Jodie Foster.
Wasn't she also in Nell? Wasn't that a movie?
Yeah.
I guess that was a movie, but it wasn't Candle Shoe and it wasn't Silence of the Lambs, so I don't want to see it. It's the only two. She's in like a billion other movies too, I think. Jodie Foster. All right. So Megan, I'd love to talk a little bit more about your meta-analysis, because I don't know if everyone here is like me, but when I'm learning about a new topic and I see here's a meta-analysis, I say, hooray, this is I'm going to read this one first and just get like the broad strokes of what it is I'm about to learn. And in reading yours, it seems like there had been a number of meta-analyses in terms of treatment related to traumatic brain injuries. There had been, I think you mentioned there had been 4 prior to yours. Yours was I can't remember now if it was the first one to look at single case design or if it was like the second or third one. But what spurred on the idea of I'm doing a meta-analysis? Here we go.
Yeah, no one really wants to do a meta-analysis, I don't think. When you mentioned that first in the intro, too, I just wanted to say to everybody, like, hang in there. It's not that bad, because no one really enjoys that word. It does not sound fun for anybody. So I decided to do this. This is something else that was really early in my career. This was my doctoral qualifying exam. So I decided there's 2 options at the time. You could do these quals, which was answering these kind of clinic-based questions in a rapid period of time, or you could slowly pull off the Band-Aid. And no one picked this. It was called a major area paper, and the goal was to publish it. So I picked that option because I wanted to learn more about brain injury. I think every opportunity I had in graduate school, any paper that came up, my poor professors, they probably always knew what I was going to do. Something related to brain injury, another opportunity to learn and read from kind of different areas of the literature and in different journals. So I decided I wanted to go down that road and learn as much as I could about brain injury and how ABA intersects with brain injury. Luckily, there was a review warranted, because that's the other thing. You can have an idea, but it might not be warranted by the literature. And in this case, thankfully, it was. So this was after I conducted the study that we already talked about with response latencies, and after I did a study on preference assessments and expanding that literature base into brain injury. I thought now it's time for me to really understand what all is out there, what we have really done over time. So it was selfish to begin with. I just wanted to learn more. But thankfully, the prior reviews, because there were several, they were all limited in some way that I felt like I could expand on. Either they only included kids or adults and not both, or just TBI and not the broader ABI. And none of them really classified interventions in a way that would make sense for behavior analysts. And none of them coded for something like functional assessment that we really do care about. And mainly what was missing was a measure of effect size to really compare efficacy across articles, and also to run them through an evidence-based practice framework that was appropriate for our field. So thankfully, there was a bunch out there, but there was still room for another one for behavior analysts.
Mm-hmm.
That's good. The worst is when you do all of the work and then someone publishes another one before you.
Oh, yeah. Getting scooped. Yeah.
Yes. That didn't happen to me, but it happened to a friend of mine.
It happened to me.
It happened to you? It happened to someone else too.
Yeah. My observational learning review, I was like, I'm ready to work on it. And then Justin Leaf and his colleagues published a review.
It's happened to me several times, and it's always a bummer in the moment, but I try to think of the silver lining as much as I can. It's like, at least you had a really good idea because someone else has done it. So at least there's that. You weren't going down the wrong road.
Yeah, we had to do an area paper as well as our part of our doctoral program. And I, for some unknown reason, chose a topic separate from my dissertation. So I ended up writing like basically 2 full dissertations.
Oh, no. Yeah, I did too. Mine was on a different topic too.
Yeah, I don't know.
So going back to the meta-analysis that you did, Megan, I know one of the things I'm always curious about, like as you mentioned, what are the categorizations of treatment, is What is that process like? Because part of me wants to say, well, there's a list, there's got to be this like master list. And I know you use some of the chapters in Cooper, Heron, and Heward to sort of inform that list. But to some extent, it seemed like the previous researchers just sort of like made up, these are the terms we're going to say were the treatment categories, and that's what we're going to be coding for. Is that really the process?
Yeah, it's arbitrary. So yeah, this was me and Jim sitting down and just thinking of what makes the most logical sense and what would give us the best information and what would something like an insurance company care about in terms of should we fund this treatment or shouldn't we? So we wanted to create categories that were distinct enough yet also large enough at the same time, because a lot of those previous reviews, the categories were enormous and they didn't really make sense. So we ended up using the chapter structure of Cooper, Heron, and Heward, and we added a few more interventions that weren't covered in that textbook, like fluency training, for example, because I had worked in the area for a little bit. I had done a couple internships by that point in time, so I knew of some other strategies that behavior analysts were using with that population. So we added in fluency training. I think we added in direct instruction as well.
All right, so that gave you your categories. And when I saw Cooper, Heron, and Heward, I said, oh, I know that book. Okay, this is coming together a little bit more. You had like a number of criteria in terms of, the categories, the interventions. You looked at so much, in terms of we talked about behavior reduction versus the skill acquisition, format of treatment, or what was the focus of treatment. Some of the papers I think were both or targeted both. And then could you describe sort of how you determined what seems to be working in the literature? Because I'm fascinated. I feel like I've seen more and more of this research recently where people are just going through the graphs, they're taking every participant and they're doing statistics and they're finding something interesting, whether there was an effect size of small, medium, or large effect. What was your procedure there?
I think the guidelines had been set for me, thankfully, because I knew nothing about meta-analyses when I took on this project. It was definitely a steep learning curve, reading a bunch of meta-analyses, reading through APA guidelines, reading through the special ed guidelines by Horner et al. In 2005. Mm-hmm. And then figuring out how can I put that into proper coding? How can I do this in such a way where I can get intercoder agreement? Every part of that meta-analysis, you had to think, I need to do this in such a way where somebody else can replicate my procedures. That was the big step. I would say it took a long time to identify all of the articles. It was months. It was a long, long time. I remember coming to lab meetings and having like a tear in my eye and Jim and Linda saying like, what's up? I'm like, I found another 14. And I'm like, oh no, it's so many. I'm never going to be done with this. But it was both exciting and, tiring at the same time. So
you find it and you're like, yes, no.
Exactly. I'm so tired. But thank goodness for my research assistants at that time. I bought them a lot of donuts because, gosh, I couldn't have done it without them. But coding also took a very long time. And then it's going through and following the evidence-based practice frameworks that we selected. So looking at each step and looking at each individual participant to say, did they meet that criteria? And just slowly filtering out the studies that didn't meet quality or methodological benchmarks. Mm-hmm. And that was, I would say, the saddest part of the project is watching some really cool ideas get filtered out because something was missing.
Can I just tweak it a little bit so I can include it?
Yeah, exactly. Because people have been doing some amazing work for a long time. Such cool ideas. But that's the goal of a systematic review. It's to inform future research. So it's cumulative, not an exploratory process, and help us understand as researchers, what are we doing right? What are we doing wrong? And what can we do next? So one of the big things we ended up finding was just overall methodology needs to be increased a little bit. The rigor needs to be increased. And we found that for a really good reason. A lot of these studies were conducted in clinical settings where they don't have a lot of resources to conduct a really top-notch research project with, treatment integrity for every session and IOA for every session and TI IOA and social validity and all of those things wrapped up into one. It's a lot of resource allocation that folks might not have in the field. So I'm not surprised that we found it, but it was a bummer to see some really cool stuff get filtered out along the way.
I was surprised also by the low amount of social validity that was included in any of the studies you'd looked at. It was 16.7% of the research papers you looked at actually were asking questions about, did you like the treatment? Did you choose these targets? Was this a relevant intervention for you? Would you want to continue? Those types of questions. That just seems so very low for, I guess some of it might have been in terms of the type of injury. Some of the individuals may not have been able to share that information in a meaningful way, but it still seems just like a very low factor. Is that something that you've kind of, taken on and made sure that's going to be in all of your studies? Or is that just sort of a artifact of the population that is receiving this treatment?
Gosh, that's such a good question. I really think it expands to all other practice areas. I don't think we report social validity enough. I don't think we think about it enough.
Same.
I would say that is a can of worms. Somebody needs to start focusing on that. I know that my colleague, Dennis Brand, we hired him 3 years ago. He's fantastic. But he has an interest in that area, and I keep pushing him to go down that road because I really want to know more about it. We don't do social validity justice, even though it's one of our tenets of ABA. It's one of the hallmarks of our field. We don't measure it in a meaningful way, in my opinion, in most cases. So yeah, it was hard to see in this review, but I think we're going to find it in pretty much any review.
Mm-hmm.
Agreed.
Yeah.
I don't think it's specific to this practice area. It's a problem. It's a field-wide problem currently. And we're making strides as far as the number of studies that are including social validity moving forward, but it's still not where it needs to be. And I agree with you, Megan, the quality of the way in which we're collecting social validity data needs to be improved dramatically.
I think one thing I did take from it that you asked, what are you taking from this in your practice? For me, it's talking to clients more so about their targets, involving them every step of the way. And there was a webinar I went to recently that the North American Brain Injury Society, or NABIS, put on about telehealth and brain injury. And one of the speakers had this phrase that really sat with me and still does, and my lab and I have talked about it, is nothing about us without us. And I really, really liked that idea, particularly in research, thinking about how I get informed consent. Like, what kind of modes am I giving the information to my clients who have struggles with language after brain injury? Do I need to present the information in a different way? And SLPs have been doing that work for quite some time. So I've been digging into their research on informed consent and brain injury to try to pull what they have figured out and what are the best ways to present information. That way, we found early on in our research that a lot of our participants, they just wanted to hang out with us. They've lost friends. That's very common after brain injury. They wanted to just hang out with young college kids who are fun and doing research. And you're thinking, are you in this for the right reason? Did you say yes for the right reason? It made me a little uncomfortable. So it's something that now I'm thinking about a lot more in terms of trying to figure out how can we present information so that folks really understand what they're agreeing to.
And the "nothing about us without us" quote is so important. And there's a call for that from the autistic community as well, to be included at all levels of decision-making and planning when it comes to treatment and care for autistic individuals too. So it's such a good reminder across the board that that's where we should be coming from.
And teaching self-advocacy. That's something that we really need to start thinking about as well. Hopefully as a future line. Hopefully one of my grad students wants to go down that road with me in the future.
You've got a whole table of great ideas for them, Megan. They must be lining up. Like, I want to be in your program because I'll just take one of those. I'll pull one down off the
I have some great grad students. I will say that. That is the best part of my job, is my grad students.
Nice.
So kind of to wrap up the meta-analysis, I mean, I think kind of the common theme that we've been discussing, without being sort of dismissive about the specific needs of individuals with traumatic brain injury or acquired brain injury, were that the treatments that seemed to be the most effective were the ones that, surprise, reinforcement did seem to have an evidence base. Wow, self-management, not too bad. That might actually be efficacious. Antecedent interventions are pretty darn good. So were you expecting to see basic principles conquer all kind of as you did, or was there any surprise there when you were looking at the final effect size results?
Well, the effect sizes were enormous. So that was really fun to find. But I was shocked at how many studies got scanned out or filtered out throughout the evidence-based practice process, putting them through the frameworks. That was the biggest surprise to me. I was happily surprised by the number of acquisition studies. I was also surprised by the large variety of journals in which we found these published articles, both inside and outside. of the behavioral journals. So that, again, kind of gets to that point of we need to be reading outside of what we're used to. And I really wanted to see an increasing trend in the publications over time, but that's not what we ended up finding. It was pretty low and variable, and it continues to be that way. But overall, I would say the main take-home point is that we have a couple of our interventions that are well-established or probably efficacious, both in terms of acquisition studies and reduction studies. But gosh, we have so much more work to do. And when doing it, we need to learn a lesson from the past of just making sure that we're using repeated measurement. That was one main reason why we threw publications out, is they didn't have at least 2 baseline data points. And making sure that we technologically describe our participants, their settings, and even operationally defining dependent variables was something that we often threw studies out for. So making sure that we're going back to the basics, right? And using convincing experimental designs.
Some of the statements you made tonight, and then also in that paper, just in terms of the settings of much of this research, they're not settings where anyone was waking up and saying, we got to make sure we got that, those procedural integrity checks going. We got to make sure we're reporting all of that. We got to make sure we're asking about the treatments. It was one of those resource intensive pieces that, well, I just got to make sure that the individual I'm working with is improving and they're seeing an improvement in their quality of life. So some of those other pieces, I naturally feel like they're just going to fall by the wayside. But you're right. It then makes it hard to say to future generations, here you go, everybody. Here are the treatments. And we know for a fact that they work based on our review of the studies, because like you said, you can't use half the studies. I know the Horner et al. Criteria seems so stringent, but a lot of them just have to do with that basic research and checks of procedure integrity and increase focus on social validity.
Yep. And replication.
I don't know Horner at all, but every time I see that paper cited and how we couldn't consider so many studies efficacious due to that paper, I'm like, is Horner, they sound like just so grumpy. This grumpy paper. They don't want anyone to have a good study.
I know I thank him for writing that paper, though, because that table that he lists all of those quality indicators, that's a wonderful checklist. That should be what we're using when we're designing studies, is using that as a checklist.
So, Megan, anything else on the meta-analysis you wanted to discuss, or are you in a good place to kind of start talking with us a little bit more about what you're currently working on and maybe give us some more details on some of your skill acquisition programs?
Sure. I would say to leave that behind, one big thing we need to do moving forward to actually make an impact on those tables and bring a lot of those intervention categories from being deemed experimental up to probably efficacious and well established is we need to collaborate more. That's the only way that's going to happen, because a lot of those post-acute rehab sites are in some pretty bizarre places and they're not close to university settings. So we need to really, I think, capitalize on what we've learned during COVID-19 and the power of telehealth and using Zoom as much as I am over Zoom and I have a lot of Zoom fatigue, using now what's available to us so we can collaborate. So folks who have the population and can help develop empirical questions surrounding their clinical issues that are common to them, bringing that to a university setting so that, in my case, I can use my lab to help with things like coding treatment integrity, coding IOA, helping design a study, helping with IRB. So I think collaboration is key. And I really hope that that's where this practice area is heading so that we can make up for a lot of lost ground in the studies that we've had to kind of disqualify, if you will.
That's a great point. Speaking ahead and speaking about lessons learned, I know you mentioned that your lab is focusing mostly on skill acquisition. And I know when we first started kind of scheduling a time we could all get together, you mentioned that you have a few treatments and a few papers that will hopefully be in publication pretty soon, if not already. Do you mind giving us some kind of sneak previews? You don't have to go into too much detail or anything, but
sure.
A sneak peek?
Yeah, no, it's always fun to talk about what's going on kind of behind the curtain in the lab right now. It's taken a while to get brain injury research off the ground in Sacramento. It's funny, all the articles that you pulled are the beginning articles, the stuff that I did to kind of create a roadmap for myself down the road when I became a professor. And now it's starting to pick off those ideas and develop a systematic way of going about answering these empirical questions. And it took a while because you have to, like we say in the LeBlanc article, you need to connect with the community and you need to really build your professional network before you can start recruiting highly vulnerable populations that don't really know what behavior analysis is. So it's taken some time. And how I've done that is I got involved with a nonprofit. Now I'm the president of it. It's called HTSP, so the Head Trauma Support Project of Sacramento. We put on free support groups every week for survivors and their caregivers. And that's been a great way for me to come up with some clinical ideas that I can answer empirically and to recruit. So it does take a while to get there because I don't have a post-acute site around the corner. That's the unfortunate part of me being geographically where I am. But what I can do is now recruit and pursue those smaller end studies and hopefully build up some relationships with larger post-acute folks across the country and use telehealth. And so we can have some larger end studies in the future. But lately we have been focusing, like I mentioned before, on skill acquisition surrounding verbal behavior. So one of my students, she graduated a little bit ago. Her name is Kim Magat. For her thesis, she replicated a study from Mark Sundberg that he conducted in the early 1990s on reteaching verbal operants. And that has been accepted at Behavioral Interventions and should be out in the next issue. It's a special issue on verbal behavior. And in that, we looked at his pub, and this is really just a great thing for master students to do, is systematically replicate in this literature base, because a lot of studies have just not been touched for 30 years. And that's the case with a lot of what we're doing right now. It's dusting off old studies and trying to figure out what have we learned through the acquisition research in developmental disabilities and autism that we can pull those updated procedures and then evaluate those. So updating those procedures in brain injury and what happens. And in that study, it was really, really interesting. The Sundberg study, they had a lot of issues with man training and not being able to teach or reteach mans. And so we updated our protocol to be very similar to what folks are doing in the ASD arena and made sure that we were using some high preference items. And we found that we could absolutely teach tax, mans, and intraverbals. And we ended up looking at kind of transfer probes or emergent verbal behavior when teaching one operant. Did we see the others emerge? And we ended up seeing that man training produced the most kind of transfer to tax, so untrained tax. And we also saw a lot of transfer when using intraverbal training and then seeing emerging tax. And I think the most interesting part of that study by far is that we ended up seeing a negative correlation between this assessment that we ran. It's an assessment called the Verbal Behavior Assessment Battery, or VBAB. And this came out of Western Michigan. It was one of Wayne Fuquay's doctoral students, Amy. And she conducted probably the first function-based assessment in the elderly population. So all of her participants were folks, I think, 65 and up with dementia diagnoses. So we replicated her assessment in brain injury. It hadn't been done before. We were just using it as a preliminary procedure to screen people in for our study. And we ended up seeing that it had this negative correlation with the number of training sessions that folks needed to reach criterion. So it seemed predictive. So for example, one participant who scored really low in tax and intraverbals on the VBAB took by far the longest to relearn tax and intraverbals compared to mans. So that was really exciting to see. We didn't expect to see anything like that. So that's got us headed down a different road. And her main research assistant, Danny Buckley, another master's student, came around and took that, and we started collaborating with John Baker from Western Michigan University, who's a behavioral gerontologist. And we kind of revamped that assessment and created a lot more sub-assessments and looked at the targets that we were actually assessing. And we conducted that with 6 other adults with brain injury just to see if we saw similar patterns. And overall, it does appear that mans are highly interrupted after brain injury, followed by intraverbals, followed by tax. Listener responding and echoics maintain pretty darn well. They're less likely to be interrupted, but textuals can also be disrupted. So reading can be disrupted. And that's really good to know, because if we ever want to use any kind of textual prompt, well, we should probably assess for that. So using this sort of assessment can help us determine what's going to be more effective as antecedent procedures down the line. So that's something we're working on right now. We're writing up that publication and hoping to submit it to TAVB in the next few months.
And when you're doing some of this work, Megan, do you collaborate with individuals from the neuroscience field? Or is that like an area of interest? Because I'm thinking back to some of my undergrad classes on brain injury and sort of, we looked at some, the fMRI scans and what does it mean when this area of the brain is injured versus that area of the brain? I mean, the assessment that you're speaking of, I feel like that would go really hand in hand with a sense of like, well, is this a common pattern? Do you see this more with individuals with injuries in these areas of the brain versus that area of the brain? I would think that there'd be, real room for collaboration there. Or is that not really a focus of your lab right now?
That's absolutely something I've wanted to do forever since I was an undergrad and I learned about verbal operants for the first time. I think we're a long way off from that, from being able to essentially establish a correlation between different areas of the brain and focal injuries, and what does that lead to in terms of functional deficits in verbal behavior. I think it's possible, but it's a ways off at this point. Right now, myself and John Baker, we're trying to find a way to really get this assessment validated. And one thing that we're going to need to do is to collaborate with SLPs to help us choose the topographies of the words that we're using in these assessments. We have just kind of selected words from old language assessments in SLP. But what we ended up finding is we ran some control participants that were neurotypical. And there are some words that folks in our generation just don't know anymore. One of them was trellis, for example. No one knew what that was, who was typically developing. Like, what is that branch thing? I'm trying to remember some of the other words that were just bizarre. A sphinx was another word that was from an old assessment. No one knew what that was if they were typically developing.
What? A sphinx?
I know what both of these are. I feel so old.
Yeah, but the younger generations, the participants we had in their 20s, no clue what those were.
I'm in my 20s.
Whether I won't argue with you on that.
Hey, we're old enough to remember when we could go visit the Sphinx, I guess.
Or a scroll was another one that folks just didn't know. So we need to update the words that we're using.
A scroll?
Yes.
Like a scroll that has like a magic spell on it kind of thing?
You're dating yourself, Rob.
We used to have a set of stimuli that included a bar of soap. And none of the kids knew what that was because they'd never seen a bar of soap.
Until they couldn't get their liquid soap in the pandemic, and then they remembered the bar of soap.
Now they might know, but then they'd only seen pump soap before.
What?
The times.
I don't like this.
They are changing.
I don't want to live in a world that people don't know what a sphinx is. I'm really upset about this.
Yeah.
This is shocking.
So right now what I'm working on is Cooper, Heron, and Heward, when they came out with their new edition, the VB chapter is amazing. It is very, very well done. So I want to make sure that we're capturing all of the verbal operants that are described in that chapter in this assessment. It's already a very long assessment, so we need to figure out which of our sub-assessments are really looking at the same thing, and do we need them all? So that's kind of where we are with validating the assessment. But we're going to need to move that to a larger scale, a larger N study, and that's where the collaboration piece comes in. So it's a really exciting area for me. I'm really looking forward to continuing to collaborate with John Baker. He's a fantastic researcher and just an awesome guy all around to collaborate with. So that's where we're at on just the verbal operants in the lab right now. I also have another group of students who are awesome. Chris Lee, he just graduated this semester. He looked at reteaching name-face relations using equivalence-based instruction. And this is, again, something that was done in the early 90s and has not been touched in brain injury since. What we ended up doing this last semester was piloting our protocol over Zoom with just typically developing college students. We want to make sure that we're refining all of our procedures before bringing in our vulnerable population. And we started incorporating multiple exemplar training, and it was simultaneous training. And we ended up recruiting a participant who self-disclosed down the road that she had a learning disability. And we actually saw major decrements in her performance, and she didn't learn with our protocol. And that was really amazing. It's one of those Skinner moments, like you mentioned earlier, where you find something interesting, you drop it and you chase it. And that's what we're doing right now, is trying to figure out what was it about that multiple exemplar training that was throwing her off. So we're looking at very in-depth error analyses to figure out, was she looking at an irrelevant aspect of the stimulus? What was she looking at? And this is one of those areas where I really wish that I had some eye tracking software, because I really would like to know what they are focusing on when they're looking at such a complex stimulus like a face. So that's one area that we're looking at right now, and looking forward to kind of tweaking that procedure in the spring. And I have a undergraduate student who's really interested in that as well. So she's going to be using that for her McNair scholarship. She's in the McNair program right now in my lab. So that'll be her kind of undergrad honors thesis, if you will. So that's another area that's very new for us that we're really excited about. And it's a really fun way for me to collaborate with my colleague, Kyle Miguel, given his interest in specialization really in stimulus control and equivalence in VB. It's a really fun way for us to have a cross-lab project.
Oh, that's fun. It sounds like you've got so many great lines of research going, so many students, so many collaborators in the field. I know, are you accepting applications?
One thing I'm so funny that you bring that up, and I know you did it in a joking way, but I'm serious. I really want to find a way, because I have all kinds of students emailing me, asking me, how do I get involved in brain injury? And they're all over the US. And I'm really starting to think, how can I help them? How can I facilitate this a little bit more? Because there just aren't very many people doing this work right now. And they can't all move to Sacramento, and they can't all be my master's student. So I really want to develop like one lab meeting a month where it's just more general, like a journal club, where more people can get involved and start learning about this literature. So at least I can facilitate that level of learning, and hopefully over time build up some connections across the US to get some more internship sites set up. So that is definitely a career goal.
That would be fantastic. I think that, like you said, there are a lot of people who are interested in the various ways that ABA can be applied. And this area is just right there waiting, right? And many people could benefit.
The big barrier is understanding funding. It's understanding why we don't have a seat at the table, oftentimes on multi and interdisciplinary teams. And that's something I've wondered about for a long time. Since Linda and John and I wrote that paper in 2013, I've been thinking about the next step of that paper and identifying some barriers. So that is another project that is in the planning stage right now. One of my students, Shelby Brians, she's amazing, so much fun. She and I are developing a barriers analysis that's going to be a survey and an interview of kind of 3 different groups of people. 1, behavior analysts who are already employed in neuro rehab settings. 2, program directors that would do the hiring of behavior analysts. And then 3, interdisciplinary team members who would work with behavior analysts. And we want to figure out, what are the main barriers? Is it that people have misconceptions of our field? Is it that they think other team members already cover what we cover? Is it funding? What is it? So that's something that we are in the planning stages of right now, and we're collaborating with a qualitative researcher in our department. And I'm really excited about that project. It's something I've wanted to dust off and actually conduct for several years, and I finally get the chance to do it.
That's excellent. And actually, Megan, that brings us to a good segue into our final section of the show, the dissemination station. We spared no expense on our sound effects here, as you can tell. Now, I think one of the great things about doing an episode that's sort of a broad introduction on traumatic brain injury is just there's so much to talk about. So there's no way the conversation is going to run out of steam, because it's such a broad area. So
Steam.
There we go. I didn't even plan for that.
It's a steam train.
But it does make it hard to do this last segment in which we sort of share, all right, what are some great take-home points? Because it's hard to say, what's the take-home point of all of the research on traumatic brain injury treatment? What's the one thing we should all know? So what I thought would make more sense, and we've discussed it kind of spread throughout our overall conversation tonight, sort of taking from your paper that you did with Linda and Jonathan on expanding the consumer base. So while I'm sure, you'll be happy to share, some information as to how people could reach out to you or reach out for resources related to traumatic brain injury, in the more general sense, not everyone is going to turn off their podcast player and say, all right, tomorrow I'm doing traumatic brain injury treatment. So if someone is interested in expanding, no, please don't do that. I'm glad you enjoyed the episode. You don't know all the information yet. But if someone is interested in, I do want to switch practice areas, or I do want to just learn more about a new practice area for the future. I mean, that is a great article that you all wrote in terms of just laying out the steps. But what would you say would be a good first, maybe even second step, or most important steps in the behavior analyst who says, I'd like to learn more about a new field? What advice would you give to the, average practitioner?
Sure. I know it sounds egotistical. I never do this with any of my other papers, But I really think that paper is a roadmap. We tried really hard in conceptualizing that paper to write down all of the things that each of us has had to do in pursuing a different practice area. Because Linda is a behavioral gerontologist. She trained John as such. She helped train me in brain injury. So did Jim. So did Mike Mazzoni. So what are all the things that we had to do? And it was such a fun process to put all those ideas out on the table and then try to figure out, how do we do this logically? What makes sense? What is the chronological order in which you would identify a different practice area, become competent enough to then ethically practice in that area? And I do think that paper lays it out in that order. So the first thing to do is just start getting acquainted with that literature base. A lot of studies that practitioners are reading are relevant to what they're doing currently. So it's likely to be relevant to their autism treatment, or they're working in school districts with kids with general developmental disabilities. So now it's time to pick up, special issues of behavioral interventions in the past have been conducted on brain injury, to pick up some different journals. The journal actually called Brain Injury is a great one to start with. So just getting acquainted, contacting the literature. If you're in school still, do what I did, be a nerd. And every time you get a paper or a presentation opportunity, do it on brain injury. Do it on that topic so that you have the chance to actually dive in and then get some feedback from your instructor on what you're doing. And if you're looking at the right things. After that, I think contacting professional groups, both within and outside of behavior analysis. We have a SIG at ABAI. It's called the RAIL SIG, Rehabilitation and Independent Living. I think we are actually the oldest SIG at ABAI, if I'm not mistaken. We're either the oldest or the second oldest, but we are small. We are a little happy family where everybody knows everybody, but they are the nicest group of people I have ever met. They are fantastic individuals. So getting a hold of that SIG and going to our SIG meeting at ABAI this year, I'll be there. Please go and get to know us, because we would love to mentor folks. We're going to connect you in every way we know how to connect you. But along with gaining that competence, one thing we mention is communication skills. And that's something to really start working on, is understanding, yes, how to talk about behavior analysis using our jargon and our technical language, but also how to describe what we do using non-technical language that's friendly to other disciplines. So it's not just thinking about how do we dumb down our descriptions, it's how do you tailor your description to someone who's very educated, but they're educated in a different area and they have different philosophical underpinnings in that area to what we do. So it's developing those skills. And I really suggest listening to Pat Fryman, because he talks about this a lot, and he does an excellent job at it. So he's somebody, if students haven't really sat down to listen to him, there's plenty of content out there that they can just watch and listen to now. So I know Sarah Troutman's new program with Ryan O'Donnell, they did a fantastic job of following Pat Fryman. I definitely urge people to listen to it. So I think those are my two big first steps, is contact folks and the literature and start thinking about how to describe what we do to someone else and practice that.
All right. Well, Megan, I think the advice doesn't get much better than that. I suppose the only other piece would be if somebody has already started on some of these first steps and they've been reading, the articles like crazy the past few days and they're sort of kind of running out and they want to reach out. Is there a contact information or a way that folks could reach out to you?
So they can reach out to my email. It's easy to remember, but you just have to know how to spell my last name, which I guess is not the easiest. So it's Megan, Megan, then a period. And my last name is spelled Heinicke. And it's at csus.edu. So please feel free to reach out.
Excellent. Well, Megan, it was such a privilege having you on tonight to talk all about traumatic brain injuries. It's not an area any of us have really been studying before. So having someone who's just, you wrote the meta-analysis, you're working day to day on it. You've done so many of the steps of entering this new field from the very beginning of your career. Was just so illuminating to sort of hear both the facts and also the practicalities of working in a field that many BCBAs may not have even realized they could work in. There was an option. Mm-hmm. So thank you so much. I really appreciate that.
Thank you so much for inviting me. It's always really fun. So sorry if I talk too fast. You can tell I'm really excited to talk about this area. So thank you so much for choosing this topic.
Once again, we want to say big thank you to Dr. Megan Heinicke for coming on the show tonight. It was a real treat to have her on to talk about a subject that we were only just learning about, and it is always fabulous to have someone who is such an expert in the field be able to share their process and their thoughts from the very beginning of Dr. Heinicke's career. So again, thank you, Dr. Heinicke. Few last things before we wrap up our episode tonight. First, I want to make sure everyone gets that second secret code word. Again, this is courtesy of Dr. Heinicke. It is NABIS. NABIS. If you remember, Dr. Heinicke mentioned that in describing some of the organizations that she'd been a group of or visited. So it is an acronym, which again, for
the North American Brain Injury Society.
Thank you, Diana. This is why we have three of us, folks, because I can't remember the acronyms very well. So NABIS, NABIS. And well, I guess that does officially bring us to the end of another episode of ABA Inside Track. We really hope you enjoyed listening to the show. We'd love it if you subscribed on Apple Podcasts, Spotify, Stitcher, or wherever you like to download your podcasts. There are a lot of other ways we'd love to be in touch with you as well. You can certainly go to our website, abainsidetrack.com, to find links to all of the articles discussed, as well as to purchase CEs for this or for any of our other full-length episodes. You can find us on social media. We're on Facebook, Twitter, Pinterest, and Instagram as ABA Inside Track. You can also find these episodes posted on our YouTube page, where we have the YouTube subtitling featured enabled. And of course, if you'd like a little bit more ABA Inside Track every month, why not come over to our Patreon page, patreon.com/ABA Inside Track, where for just $5 a month, you can subscribe to join our monthly social BCBA get-togethers. We have them coming out almost the middle of every single month. We get together with other fun, like-minded individuals to chat about a given topic or just to chat a little bit about what's going on in the state of the world, busy times and all. You also are able to, if you're interested, subscribe at higher levels to get access to bonus podcasts as well as discounts at our CE store. That's again, patreon.com/ABA Inside Track. Thanks to so many people who helped make this show what it is, to Dr. Jim Carr for his intro and outro recording, Kyle Story for his interstitial music, Dan Thabit of the Podcast Doctors for his editing work, and Hollis Irvin of Sycamore Workshop for his visual designs. We'll be back next week with another full-length episode, but until then, keep responding. Bye!
Bye!